Hello, everybody, and welcome to today's webinar. We are very excited today to have Cindy Krafft and Sherry Teague presenting Delivering Care in the Home in 2022 and beyond. This will be part one of our two-part series. Part two will be March 16th. Before I turn it over to Cindy, I would like to cover a couple of housekeeping items. The first is that we are recording today's session. The recording will be available within 48 hours and will be emailed via Zoom to all those who registered. It will also be available to all NARA members in the portal within 24 hours. The handouts were provided to all participants that registered an hour before today's session. Christy has also just posted it in the chat for easy access for all of you. If you have any technical issues during today's webinar, we ask that you type those into the chat. Christy is monitoring those and will be able to assist you. And we're going to ask, because this is a two-part session particularly, if you have any questions for Cindy or for Sherry, please type those into the Q&A and we will be monitoring those as well. So with that, Cindy, I'm going to turn it over to you.
Thank you very much. And Sherry and I are very excited to be with you today and to have a two-part conversation because there's a lot of ground to cover. I want to reiterate the value of the Q&A box. Sherry's going to play the role of monitoring that for us today and interjecting those questions as we go if the topic fits with that, or facilitating a Q&A time at the end. But we appreciate your engagement. Questions about provision of care in the home is how we got here today, because NARA reached out to Sherry and I saying, we're getting some questions about home health. These things kind of keep popping up. Would you guys want to help to address some of it? So I asked to see some of these questions, and the themes of those questions help to shape what we're going to talk about today. They are the building blocks of part two, but the Q&A box today could be very useful for individuals who come up with something that we may not have thought of yet and could round out part two. So that one is not completely final. So if you have a question or a burning issue you would like to see addressed, we're open to examining that through the Q&A box today. Also want to acknowledge some folks are listening to this in the recorded version and go, I got all kinds of thoughts. I can't get to the Q&A box. You have my email address at the very end. Please feel free to send an additional question or comment in that direction. So what we have here are objectives. If you have not been to a Cornetti and Krafft presentation before, you will learn very quickly that we are not slide readers. We have to provide certain pieces of information like objectives so people have that in hand, but we really want to be able to focus on the meat of the issue. And so our slides serve to frame the conversation, but are not going to be something that we read to you or that have so much stuff in it they're not particularly useful. So why are we talking about home-based care? Some of you may have participated in a session that I did for a recent conference where we talked about the differences between Part A and Part B in the home. That is not what these two sessions are. We are going to touch on some of that because if we're going to be taking therapy into the home space, we absolutely have to make sure we understand the regulatory context. Okay, this is not just an issue of we can go in because this seems like a great opportunity. We want to make sure you have tools and resources so that you know what you may or may not be getting yourself into if you haven't been in this space before, or if you are in this space and you're being told, you know, some of my favorite things are if anybody tells me you always should or you never can. Those are two words that immediately take me to, can you show me the regulations that support that? Especially on the you never can front. And that's where some of the questions that formulated today's content really came from, was a place of how many visits can I do? What's going on in that Part A space with respect to utilization? What are some of those challenges from a clinical perspective, whether or not it's Part A or Part B? So we're going to talk a little bit about regulation because we have to make sure you understand some of the fundamentals. And a big one, regardless of if you're going into the home under A or B, is we have to understand Medicare A and the homebound criteria. Okay. Homeboundedness is a qualifying criteria under Medicare Part A. Okay, that means you could have a patient who absolutely needs skilled therapy, but they don't qualify for it in the home under Part A unless they meet several criteria. And the one that I think gives us the biggest sticking point, especially as therapists, is being homebound, especially when it's framed as confined to home. It's been perpetuating a myth for a long time that this means these have to be severely debilitated individuals. I talk to young professionals who still try to tell me they think, home health is for every, people that can't get out of bed. They think it's a very low level of function. And, that term confined probably perpetuates that idea. I think this also is a big sticking point, particularly for physical therapy, because what we do is so tied to mobility, particularly ambulation. And so this leads into whole conversations about what is essentially the guardrail in place around homeboundedness. How far is too far to walk? So what I want you to see on this slide is that there is absolutely nothing in the Medicare Part A home health benefit that ties homeboundedness to gait distance. Okay, the gait distance is not a deciding factor. And for those of you currently practicing in Medicare Part A home health, please, we'd have to be very careful when our electronic medical record systems throw up these arbitrary reasons for homeboundedness. The ones that drive me insane are the patient cannot ambulate more than 10 feet. And the PT or the PTA marks that on the visit and then walks the patient 50 feet. Okay, wait a minute. You just said your homebound reason was they couldn't walk more than 10 feet. And why is that even being used? Because there's nothing in here about that. To define homebound, I have to meet both criteria 1 and criteria 2. Criteria 1 is speaking to the inability of the patient to leave the home without some sort of assistance. So the first part speaks to more of a physical mobility impairment model, which is typically what we see is the overwhelming reason under criteria 1 that an individual is deemed to qualify for home health. The getting out of the home, they need significant help. They're not able to just come and go as they please. Then why is there an or? Well, this or became an even bigger deal in the recent issues around the pandemic because you can also meet criteria 1 by virtue of a physician restriction. So the infection concern, the pandemic concern, if the physician was stating that the patient needed to remain in their home for a medical reason, then we could meet criteria 1. But it absolutely had to be a physician restriction. It could not be the patient is afraid of getting COVID and so does not want to leave the home. That does not meet that criteria. So as long as I meet one of criteria 1, I go over to criteria 2. And this is where people can get even more confused because it talks about a normal inability to leave the home, and leaving home requires a taxing effort. So since this is predominantly a therapy audience, that's where I want to take the conversation. So if we're trying to decide, is this patient really homebound under A, or should they be receiving Part B, where homebound is not the issue? Let's think about the patient needing to have therapy in a brick and mortar clinic. So what does that involve? I think we immediately, if we're on the Part B in the clinic side, envision the patient comes to me, we do therapy, they leave. But I think sometimes we forget that it's a more complex task. It is the issue that the patient needs to get dressed, they need to have their medication, they need something to eat, in particular with certain diagnosis groups like diabetes. You don't want them to have skipped a meal to come and hurry up and get to therapy. Then they need to get into the transportation and be transported to the brick and mortar facility. Sometimes I think we forget about this whole normal inability and taxing effort is for some of our patients, all that stuff before they get there has tapped them out. All the energy, all of the strength, the aerobic capacity, the cognitive bandwidth went into that. And so by the time they show up in the waiting room, they are not in the best position to participate and benefit from this care. I remember my days in outpatient, and this was before I started doing home health. And I could not understand, here we go again. The patient is here, but they're asleep in the chair. Okay, now I got to go wake them up and try to get them to do some therapy. In hindsight, I feel horrible because I'm like, wait a minute, I don't think these people were appropriate to come to the clinic yet. Okay, all of their energy reserves got consumed in the process of getting here, but I'm not done. So now this individual is going to participate in therapy anywhere from 1 to 3 hours. If they've got all 3 of us ordered, they could be here a while. And then they need to go home and still be able to function. That's what we're looking at in terms of a patient's abilities. come and go as they please. This is not about the person walks a certain number of feet, or the person got to the car today and they made it to the car door. Oh my gosh, they must not be homebound. Or I'm seeing a person in assisted living and he can walk down to the front door of the building. He can't possibly be homebound. He must be a Part B person. Wait a minute. If he was going to come and go to do routine activities, that whole activity of getting ready, doing what you need to do and come back, that's the level of ability we would have to see to say you are not homebound. So I think what's happened is we've shrunk it and shrunk it and shrunk it and heard all kinds of things on the PT side about 150 feet. Oh my gosh, if they go 151, they're no longer homebound. None of that is in the regulation. So we have to make sure we have a clear understanding, even if we do not provide Medicare Part A, we have to know what those boundaries are to say, if I have a patient in front of me who clearly needs therapy, but this is not going to fit in my setting, would it be better that they're referred to a Part A provider for a period of time to build up those reserves and then come to your clinic and be ready to go and benefit? The next few slides, again, I'm not going to read them. I wanted us to see where there is a strong similarity between home health coverage criteria and Part B coverage criteria, and it speaks to what is the focus of care. We can take one of three pathways, okay? The one we are most familiar with and happiest to do is restoring function. So we look at this individual and we believe that this person can be better if they get therapy. That's universally true, whether it's in the home or in the clinic or Part B in the home. We can approach this from a restoration of function. But we start to see for both A and B that there are two other paths to take. That if we don't really believe that restoration is possible, we need to be looking at a maintenance course of care. And maintenance can take two different ways, two different pathways. One is to say that my job as a therapist is to establish this maintenance program, that this program is going to focus and emphasize stabilization of function. So my role is to create the program, to design it, to teach it, to periodically monitor it. But the actual execution of said program is not going to be what a therapist is doing. The patient themselves could be doing it, because maintenance does not mean that the patient is, severely impaired either. They don't have to have ALS, MS, or particular Parkinson's type disease processes. This is a situation where, from a functional perspective, I have something to teach and train and impart to help you preserve your function. I don't think we can get you better, but I do think there's things we can do to preserve what you have. So that second path for both home health and brick and mortar and be in the home is that I am going to establish this program that someone else is going to follow through. If I still believe a stabilization approach to care is what needs to happen, but the complexity of the patient and or the complexity of my program is such that a therapist and only a therapist can provide it, I can do that as well. That is a separate maintenance pathway to take. Okay, and you can imagine, if I am saying this, if this is my focus of care, I absolutely have to be very clear as to why I'm saying a therapist and only a therapist can provide these things. We can utilize therapy assistance for the provision of maintenance in the home, okay, under A or B. Now you can think about that first maintenance path with all of this designing and reevaluating and adjusting seems to be more the wheelhouse of the PT and OT and SLP and not the assistants. I would agree. We see more of an opportunity under that third path of it's still maintenance, but a therapist and only a therapist can do this stuff is an opportunity for the inclusion of the assistant. But this is very common ground, and very often those, door number 2 and door number 3 are kind of like, yeah, I don't really touch those doors. I'm over here in restorative land and everything is good. Especially when we're talking about care delivery in the home, the ability to stabilize function, to preserve mobility, to reduce the risk of higher cost care, which we're going to talk about in more detail in part 2, is a huge way we contribute to value in the home health setting. What else absolutely has to be consistent is when I am providing care in the home, am I clear about it being skilled, reasonable, and necessary? And skill, we can be our own worst enemy here. We are very comfortable with the skills we have accumulated over time. But what we have to acknowledge is, what am I bringing into this visit that only comes from someone with my training and expertise? If someone else can do this, I cannot just come and do this to be nice. And any care delivery in the home changes the dynamic significantly from a clinic with respect to, you are now in their space. They have a significantly more control over the setup of said space, but we have to make sure we're following those boundaries of, I cannot just come and do this because they want me to. I cannot just provide care in the home from a convenience standpoint. It absolutely, have a responsibility to the third party payer to make it very clear that what I'm doing required my training and expertise, and that what I'm doing fits with acceptable standards of practice, that it's reasonable to expect therapy to be providing care in this situation, and that what we're doing is absolutely essential. That if the individual did not have access to care, that their outcome would not be as good as it is with our services included. So why I set the stage this way is, when we get into more specifics about the home, I want to make sure we don't lose sight of the fundamentals, because there is a lot of discussion right now about people who want to be at home. It's even more so with the pandemic issues and concerns about the SNF situations. And so it's becoming, we need more and more services in the home. Yes, but we always have to understand what the parameters of the benefit are, and our accountability to always being clear why it took a therapist to do this for this individual patient. Now, we had some other regulatory related issues come into play related to waivers. On the Part A side, I need to make a very clear statement, okay? There is a difference between a waiver and an actual regulatory change. And in the final rule for 2022, that got a little, CMS believes they said it clearly, but then as people started to ask questions, the responses got confusing because it was muddying the water. So under the waiver, which is still in place at the time we're doing this session today, under Medicare Part A, even if nursing is ordered, a therapist can be the first one in the home to do that start of care admission to home health services. That is a waiver situation. That is not considered a regulatory change. So when people query CMS about a regulation, and CMS answers about a regulation, and we go, but that's not what the waiver says. That's true, because a waiver did not change the fundamental regulation. The fundamental regulation remains intact, that when the waiver is no more, if nursing is ordered as part of that plan of care, they are the ones who have to open that case. They need to do that initial comprehensive assessment. The only reason we have a workaround at this point in time is the waiver. I am shocked by how little this is actually being used. We do outsource coding and OASIS reviews for agencies. So we are seeing these admission visits, these start of care visits, and they are overwhelmingly still nursing. And therapy is doing their evaluation a day or two later. And I don't understand, when everyone's talking about shortages and chaos, and every morning a circus of trying to figure out who's going to get these patients seen, why we don't see more therapists stepping up in that space to say, I can do the admission. Even though nursing is here, I can do it under the waiver. How can I help? What has moved from waiver to regulation change is about OT. So in the infamous therapy only case, where there is no nursing ordered, it is not part of the plan of care, and OT is part of that order along with either PT or speech, OT can do that admission. They can. Yes, they still have to be in terms of ordered with PT or speech, back to a qualifying service issue. This is nothing about the qualifications of OT. OT is absolutely a skilled service. This is not what this is about. But the regulation remains that if the only need this patient has is for OT, that does not meet the standard of having services under Medicare Part A in the home, if that's the only thing they need. But here again, we saw this happen with the waiver, trying to give us more flexibility that says, if OT is in the mix, let them have at it. And we're not really seeing anybody take advantage of it. And this particular situation in the therapy only moved in 2022 from waiver to permanent. So this is not going anywhere. So our ability to utilize occupational therapy in this capacity is significant. And agencies that are like, nah, no, we won't. Why would you not, as an OT, want to get that training and expertise to be able to be on equal footing with respect to this admission issue? So why do I have telehealth? Well, telehealth impacted home health two slightly different ways, and this is about the payer source. Medicare Part B went the route of allowing for payment for telehealth services. So yes, that is in play. If you are a Part B in the home practitioner, those payment issues related to telehealth work in your favor. This means the Part A size goes, see, I told you, it's not paid for in home health. Okay, it's because under Medicare A, we are not paid by procedure code. We don't have treatment codes or anything like that. We have visits. We report visits and the discipline who did the visit, not the code. So this idea that telehealth isn't paid for isn't completely true. Yes, before you start filling up that box with there's expenses with it and I get it. And there needs to be ultimately some sort of adjustment to account for that in Medicare A home health. However, we're paid for an episode of care. We're not paid by visit. We report off by visit on our claim, but Medicare gives us a lump sum for a period of time. So why would I not look at utilizing telehealth in this space? Because telehealth, and this conversation went on well before the pandemic, and after our closing slides, there's several additional slides. They provide you with additional resources about this issue of telehealth, because this should not just be about if it's paid for, I'll do it, and if it's not, I won't, or it's not covered at all in home health. What is asked of home health is if you're doing this, they want us to report it. They want us to track it, because ultimately, if we're going to ask for any sort of payment adjustment, they're going to want to see what the impact is. And if I'm being paid in a lump sum for an episode of care, and telehealth can really be a great adjunct for my patients to better manage them and have more deliberate interactions with them, not just go a couple times a week whenever, but let's track things like their vital signs and say, when is the right time to go? It can be a huge asset. So I want to dispel the myth that says that, oh, if in B you can do it, but A you can't because it's not paid for, is not technically accurate. But you can imagine that the pandemic absolutely raised the conversation up and says, what could we be doing with this? Unfortunately, on the Part A side, sometimes that conversation stops strictly off the issue of traditional telehealth. So the monitoring of vitals, the equipment that's been around quite a while and not necessarily used the most effectively in the Part A space. We need to remind the industry that tele-rehab has been going on for a long time, a very long time before the pandemic. I mean, you go to therapy-related conferences and I get blown away by the booths with the different ways to monitor activity and prompt, and now with apps and all of these things that could be a whole other conversation in and of itself. We just have to understand that Part A can be a little behind the times. Let's just put it that way, with technology, comfort with technology. And I just don't want to see the conversation be very tunnel visioned on it's about vital sign monitoring. It's about some nursing thing that we're going to okay, that can be part of it, but tele-rehab already has significant research and data behind it about getting patients engaged in activities, being able to track and trend activities. And we got to stop with this idea that home health patients are all really, really old people that hate technology. We're finding more and more of them are more tech savvy than I am. And as the demographic continues to shift, we're going to find people that are going to demand this from us in the home health space. But kind of an extension of the how come tele-rehab hasn't been in home health prior, we have to take a brief look at the Part A history. Prior to PDGM, we were in a different payment model, the prospective payment system, and CMS acknowledged when they built that thing in 2000 that not a lot of patients were getting a ton of therapy. And so if we're trying to get away from paying per visit, which they took home health Part A off the per visit model over 20 years ago and said, we're going to give you episodic payment. lump sum X number of days, you figure out what this patient needs to achieve desired outcome. They recognize that the characteristics they were gathering to calculate payment, therapy ended up being one of those characteristics because there wasn't a lot of it going on. And when it happened, it wasn't a ton of it. So when they developed the model and started putting dollars to therapy visits, looking at higher intensity therapy would mean a higher cost to the agency. So we should provide additional resources to supplement that. Unfortunately, the industry started to do that. And more therapy and more therapy. Some of you may remember we started out with a 10 visit threshold that then tons of patients were getting between 11 and 13, just over the 10, but not wild and crazy. So they took us to the 6, 14, and 20, and you saw explosive growth in the 14 or more, and then the 20 or more, and all this hoopla. That this is how we ended up in the current model of PDGM that jettisoned the therapy count. Now the problem is, part of our industry thought that that meant they jettisoned the therapy, which is not the case. The payment levels in PDGM were calculated looking at utilization of therapy in the previous model, saying that if patients needed that amount of therapy pre-PDGM, then our payment levels need to account for the costs associated so that essentially agencies continuing that same level of care will see a very similar revenue in PDGM. There was nothing about this that said, we don't want you to do therapy. But our industry started to interpret it that way, which our next few slides are going to examine, which was then not helped by the pandemic. Okay, the public health emergency kicked in. It became an issue of what are those essential services? Is therapy essential or not? Patients, especially in the home health space, getting out of the hospital by saying they'll agree to home health, but then not wanting anybody to come because they were afraid of getting infected by the home health provider, or I'm going to let nursing in, but I'm not going to let therapy in. If I let therapy in, you only can come once a week or once every other week because I don't want all these cooties in my house. Very valid things happened that were related to the pandemic. But our utilization shifts. We cannot just look at this and say it was all the pandemic. It had nothing to do with PDGM. It was all about the pandemic. Yes, PDGM started in January of 2020, and by March, April, we were up into the pandemic, but there is a window. And that window, which is very interesting, is in February of 2020. We were only in that model a month. CMS came out with a Medicare Learning Network statement about the role of therapy in home health under PDGM. I included here. You need to get your hands on this document if you haven't looked at it. It makes it explicitly clear in detail that there was nothing that changed in Home Health Part A about coverage criteria for therapy. PDGM did not touch coverage criteria. So if patients still meet the qualifying criteria to be in home health and the amount of therapy we're recommending is warranted as skilled, reasonable, and necessary, then that is what they expected us to provide. So it's almost like lesson learned. They didn't wait 6 months, a year. They came out of the gate because they were already hearing reports in the end of 2019 about agencies saying, well, we don't provide that much therapy, or you don't really need the therapy, or patients who'd been getting therapy all along that got dropped like hot potatoes when they went into 2020, claiming that PDGM doesn't pay for X, Y, or Z. Yes, it does. And CMS made sure to back that up. But then we look at our own data. This is from the early days of PDGM. So we're not talking about it being overwhelmingly deluged by pandemic. We're talking about looking at one of the elements of PDGM is their level of functional impairment. The level of functional impairment does factor into reimbursement. So when they built this model, what they wanted to do is figure out what they anticipated. So when they built it, they were going to take functional impairment into consideration, and they wanted the points basically distributed to make it so they would expect a third of the patients to end up in the low impairment, a third in the medium, and a third in the high. They were looking to level out the distribution. So what happened in early PDGM? Well, the medium impairment group turned out to be about what they expected, but there was significant growth in the high impairment. well above what they expected, and significantly lower low impairment. Where is this impairment coming from? Well, how are they measuring? Part A people, it's not the therapy evaluations. It's not whether or not we're even included in this episode of care. This is coming from the OASIS and the functional OASIS responses that are under complete control of the agency as to determining what level you're going to pick as accurate and send in. So you can imagine from CMS's perspective, you go, okay, I'm going to give you the benefit of the doubt. Okay, I'm a little suspicious because all indicators were it should have been about a third, a third, a third. Now you're saying PDGM kicked in and a bunch more people have high functional impairment. All right, if that's true, what would you expect to be going on with the therapy? Not this. Not this. So at the very same time, the industry is reporting a significantly higher rate of high functional impairment. We're also seeing a downward trend from rehab use. And all indicators, and I put some of that information again in the resources at the end of the presentation, indicate, even in the latter part of 2019, that people were being downsized, that they were not getting as many hours, that they were having additional, restrictions placed. Now, I will say some of this was equalizing out reality. I will say, being in the home health space for over 25 years now, there have been situations where I do agree the therapy seems a bit overutilized in the previous model, or that therapy kind of got to do whatever we wanted without a whole lot of accountability because that's what we put down on the plan of care. And if that was a nice big number, not crazy number, they don't like 50, but if you were getting right around that 20 sweet spot, nobody really questioned your clinical judgment. Maybe we should have. Maybe we could have been a bit tighter and more effective in some of these situations. But what's interesting in this graph is, yep, it started to decline at a much steeper rate for rehab. And then as the pandemic unfolded, nursing has appeared to rebound. Therapy in the early part here appears to have not. So you can play the role now of CMS for a moment and say, okay, so you're telling me there's more functional impairment. Your therapy use went down. Now you're trying to tell me it's because of the pandemic, but the rate has stayed down. So given our history, given this more recent data, as therapists, we have to understand that CMS is very suspicious about utilization. And before we say, well, it's their fault, they built the model, look what they did, I think we have to acknowledge some of how we're going to have to redefine our role. Okay, we didn't have necessarily a whole lot of checks and balances when we threw a lot of visits under Part A before. We do have them now. Okay, we have an accountability to say, what are we going to do in refining our therapy care? I don't get an unlimited pass. If I'm taking my Part B in the home, I can write a plan for 90 days, but does this individual need 90 days of care? And how am I making these decisions? And the days of I'm a therapist and you're not, and so I know stuff that you don't, and so my care delivery is always above reproach, are not productive. We need to be looking for our opportunities in telerehab. We need to be exploring our connection to these social determinants of health. And OASIS E is coming on the Part A side, January 1 of 2023. And many of the new items touch on social determinants of health. Has their lack of transportation, their lack of mobility impacted their ability to get food, to get medicine? So this is not just as a physical therapist, can I get you to walk more? And it always ends in zeros or fives, and okay, it's home health, so I'll say you can walk to the mailbox. What about that mobility needs to connect to them to be able to do their normal roles and responsibilities, and this opportunity around maintenance therapy? And thinking about information that's available, the data we just showed you, how do we utilize that to say, our utilization of therapy needs to come back to a level that is more representative of our patients? And has that been colored in a very significant way by the pandemic? Yes. But I believe on the home health side, we're always at the end of a wave, okay? Big things happen in the hospitals, then they hit the nursing homes, then they hit home care. I believe a lot of the discussion and the things around long COVID, the long-term repercussions for those who have survived this disease, we haven't even touched the tip of the iceberg on the rehab side about what that's going to mean. So as providers in the home, we're going to have to be thinking proactively, always with how do I provide the right amount of therapy in the right way to the right individuals, not too much, definitely not too little? And how do I make sure I'm part of a conversation and not, well, this is all about nursing because it's home care. It's all about nursing. And yeah, you guys take, the hips, the knees, the strokes. That's your guys' stuff. But we need to do a better job of being our own advocate and thinking beyond a visit number, because on the Part A side, as long as we hit a number, everybody thought that was great. Beyond how many codes am I generating, which codes am I using, and saying, how am I becoming a better patient manager? How am I embracing technology, not just EMRs and our love and hate with those things, but how am I integrating technology into my practice? How am I looking at reducing higher cost care? Again, a big focus in part 2, because there are so many pieces to discuss, whether it is the expansion of value-based purchasing in the home health space, the cross-setting measures that will impact rehab in inpatient rehab, in SNF, in LTACs, and in home health. I mean, there's a lot of discussion about, are you keeping people out of higher cost care? So this is way beyond, I need to have, the number of visits that I did or the number of touches I have with the patient, but what is my emphasis? And am I using the full scope of the benefits? So I like to use this graphic when we're thinking of.
You real fast, Cindy. Let me
Yep,
interrupt
sure.
you. I have a question, and before you move on to the next topic,
Okay.
I want to make sure
Cool.
I got it in. Is the allowance of OT to complete the start of care just a CMS regulation, or are private insurances allowing this? Also, what about individual state regulations and practice acts? Must they be considered? This individual that's asking this question has avoided moving forward with OT completing the start of care because they were unsure of the exact guidance and regulations, and they felt like they didn't get enough information from AOTA. Can you clarify that one more time? That's a question we get often, and I know you want to clarify that question. So go ahead.
Okay. So the ability to complete that comprehensive assessment and start of care by OT is a CMS regulation under the Part A Medicare home health benefit. Okay. So that moved again, it was a waiver. Now it is changed in the regulation to state that that is appropriate to occur. The ability of an OT to complete that activity is no different in a technical sense than if a PT does it or if a nurse does it. This individual needs to receive appropriate training to know what is included in that comprehensive assessment, because now you're getting into other standards of things like the conditions of participation, what has to be included, what constitutes a comprehensive assessment. I can't just go do an OT eval and fill out an OASIS. Okay. And if I'm going to be filling out an OASIS, I want the appropriate level of education to do that, which will always, not the OASIS, but the rest of the comprehensive assessment, bring in scope of practice issues. And yes, state-specific things are going to need to be looked at, but can I please encourage it to be in a positive way? Because sometimes what happens is a well-meaning organization believes that the comprehensive assessment is a whole bunch of nursing requirements, a therapy evaluation, and the OASIS. Now, let's be careful here. Things that are truly nursing specific, like I'm getting all in the weeds about how you handle your medications, like I'm way in depth on some of this disease process stuff. Clearly, that is not what you're being asked to do at a comprehensive assessment. A comprehensive assessment requires you to look at a variety of issues as a screening. And if I do this as an OT and I see a need for nursing and nursing was not on this order, I am going to be calling the physician and asking for a nurse. I'm not going to pretend to be one. So if you find language in your specific scope of practice or your state practice act that flat out says you cannot do X, Y, or Z, then we know that's a deal breaker. You can't do it. But a lot of the comprehensive assessment stuff about taking vital signs, asking and inquiring about how you manage your medications, looking at the holistic view of the patient is encouraged by our professional associations and not prohibited in our practice acts. So sometimes what I see, and I would think that PT has broken some ground here ahead of OT in what is a comprehensive assessment and what is truly nursing stuff that nurses need to go do. But anytime we're stepping into a comprehensive assessment space, there can be anxiety because I'm being asked to do stuff I wouldn't normally do on an OT eval. Correct. You're screening for other issues. And if you find issues, oh my gosh, they need a social worker. Don't have an order. I'm going to call the doctor. Oh, it was OT and speech. Oh my gosh, that looks all kinds of PT stuff. I'm going to order an evaluation. That's the purpose of a comprehensive assessment, is to vet the holistic needs of the patient. Now, particular to other payers have allowed OTs to admit way before the waiver, way before the pandemic. I would imagine, many private insurance companies are like, I don't want to pay for PT on top of OT if they don't need it. I don't want to be paying for nursing on top of OT if they didn't need a nurse. So that requires diligence in discussing it with other payers as far as what their standards are on this. But Medicare's saying, yes, you can. You want to make sure your comprehensive assessment is comprehensive and that we don't cause panic by making them think we're turned OTs into nurses. We didn't do that with PTs. We aren't trying to turn PTs into nurses either, or speech paths into nurses. It's about expanding our viewpoint to screen individuals for other issues. If that wasn't clear enough, the Q&A box is still available if you want to add some thoughts additionally to that. What I have here in the graphic is to help us think about the full scope of the benefit. So whether I'm assessing or reassessing that home-based patient, I'm going to decide, listen, I've evaluated you, I'm reevaluating you. I think there's a chance to get you better. Okay, but I need material improvement. So I start down that path. Wait a minute, that doesn't mean everybody who can get better needs therapy. I have to ask the secondary question. Do you need me to make that happen? If you need me to get that improvement, then I'm going to take my restorative course of care. If at the time of assessment or reassessment, I'm like, listen, this is probably the best you can function, all things considered, I don't see an opportunity for you to improve, I still have to ask the question. If I want to help you stabilize, do you need me to have that happen? If you need skilled therapy to stabilize your function, that's what maintenance is for. If you don't need me, if there's nothing for me to teach, train, or do, then you don't need therapy. So what's with that other piece? Because what we commonly see in terms of the utilization of maintenance therapy are patients that start out on that material track, reasonably so. All things are great. But as we've done this course of restorative care, we reach a plateau. And for some patients, yay, you're all better now. There's nothing more I need to do. Go forth, discharge you, happy day, throw the confetti, you're done with therapy. But then there's other patients, we get to that plateau, which is not a dirty word anymore, and go, you're better. I'm just not convinced you're going to stay that way. And not because of compliance and not because, you don't want to do stuff. It's because of your disease process and everything else going with it. I'm not sure this plateau is stable. If it's not stable and there's more for me to do to stabilize this, I can pivot to a maintenance approach to care. So we got to think about all of these pieces as we define our value in the home health space, because CMS keeps putting this emphasis on function. In the value-based purchasing, in the cross-setting measures, we have to be dealing with function. And who is better at dealing with function than therapists? And in the home health space, we have got to stop making this only about falls. Okay, there are many different elements of this than we're just going to stop people from falling. And it drives me crazy. And Sherry knows this. When I see care plans where the goal is patient will not fall during this episode of care. Really? So as long as you're my patient, don't fall. After that, whatever, you could fall then. Just don't fall while I have you as a patient. And this is home health. I could move in with you and you could still fall. I mean, it's not like my physical presence 24/7 would necessarily stop that either. So we have to be thinking bigger. So what I have on the next few slides, and the citation is at the bottom, comes from research. And a good friend of ours in many cases with the research I've included is Dr. Jason Falvey. If you don't know who that is, you're not sure who that is, Google him. Go ahead and find the article, look at the whole piece. I wanted to include it in here because we got to stop with Cindy Krafft trying to do a rah-rah speech about rehab in the home health space. There's research that indicates about the intensity of services in the home post-hospitalization and their correlation to reducing risk. Notice it doesn't say if you get a ton of therapy, that's what keeps you out of the hospital. But it says with appropriate dosing, the inclusion of therapy, particularly initially upon return from the hospital, greatly reduces an individual's risk of going back. And notice, this is not saying specifically under Part A. This could be an individual, high functioning level, but still having challenges individual who's been hospitalized, who comes home, who's not homebound. Oh, they don't get follow-up. We'll just wait till they're better and go to a clinic. Are you sure? Because in this wait and see time, risks can develop related to function and other issues that can prompt their return to the hospital. Research indicates some very interesting facts that when the discharge recommendations coming from physical therapy on the hospital side are replaced with a less intense follow-up, readmission rates are 3 times higher. To our OT friends, no shock here, declines in self-reported ADL ability strongly linked to poor outcomes following hospitalization. So patients even admitting that they're having trouble with their self-care. And yeah, they're in the hospital, they get washed, they get food brought to them, they get their clothes handed to them. That's not how this works once you get back home. How are we managing ADLs? Because not meeting those ADL issues, again, readmission rate goes up compared to individuals who had a plan in place to address this after discharge. And my personal favorite, who knew it could be this specific, older adults who walk less than 4,691 steps per day over the first week post-discharge are more likely to be readmitted within 30 days. Now think about that. There's no walk to no mailboxes. This is not even a gait velocity conversation, although we can have a whole one about that. This is saying people that come home from the hospital and sit as older adults are creating risk of going back. So again, this does not necessarily, for some patients, get out there and get your restorative hat on and they can only take 10 steps and I'm going to get them to, yes. But you could also have somebody who has the ability to walk nearly 5,000 steps, but they're afraid to. They have heart failure. I don't want to push myself. I might die if I do all this stuff, so I will just sit. I'm not going to improve you, but I can stabilize you at 5,000 steps by getting you to do it, by giving you strategies, by giving you guidance. I'm not going to come 3 times a week and walk you like the family pet. You know, can't walk your old person, the therapist will show up and do it for you. But I'm going to give you tools and strategies to be able to keep that level of function, especially initially. Because how many of our patients go home and what do they want to do? They want to sit. I'm going to sit and wait till I feel better. Might not be the best plan because they have spent a lot of time doing nothing from a mobility standpoint while they're in the hospital, triggering this hospital-associated deconditioning, a known condition. Do we speak to this when folks come back home? When you think about it, when you do the math, between 83% of the hospital stay in bed and 12% of it in a chair, that is 95% of the time an older adult is in the hospital, they're in bed or a chair. They're not doing anything. So this is not a criticism of hospital therapy. But in the hospital, there's so many procedures and acuity and all this other stuff going on. That's a whole lot of not moving. And even being in the hospital for a few days starts to trigger a level of deconditioning in the older adult population. So why would we not be prepared to take them on the home health side and say, what are we going to do better? But what does research indicate there? We're hedging our bets. We're looking at some of these folks and saying, well, they're older adults, they have, medically complex conditions, and are we picking activity programs or exercises that we are being a little too conservative on? And I'm not talking about just to start care. I've been there, been in home health a very long time, been in that home and that person does not feel well. They're annoyed about all these people coming in and out of their house. You got to build that trust. So maybe my initial exercises on that first visit are some long arc quads and, yes, the infamous ankle pumps, but trying to get them to see that movement is not going to kill them. Okay. Giving them a very low level program just that first time. So we build some trust. But when I'm reviewing records and long arc quads and the ankle pumps are a cornerstone of this program 3 weeks in, what are we doing? Where's the resistance? This is not what we were taught in school to do, to say, well, and we're doing, active range of motion in the upper extremities with what? No resistance at all this many weeks in. I wish strengthening worked like that. I also wish people would gain strength, as gets documented very often, after a week or 2 of therapy. That'd be fabulous. I'm going to go join a gym for 2 weeks. I'll get my, 1 grade strength better. Life is good. a lot of this stuff takes time, and it takes patient-specific dosing and building of programs that use resistance. So this is a great article about thinking about exercise prescription and shifting that paradigm by better understanding hospital-acquired deconditioning. These people are coming to us having little mobility the time they were in there, very often hesitant about what to do now that they're home. At a minimum, the demands of self-care and home management, the IADLs, are way higher at home, as well as other issues we don't necessarily think about as therapists. How are you going to manage your medications? Oh no, that's a nurse thing. Really? Really? Where do you keep them? Because if I'm concerned about your mobility, your strength, your cognition, your fine motor, how am I connecting that to the management of medication? I'm not talking about going down the rabbit hole of side effects and interactions and dosage. No, I'm saying the pure functionality of managing yourself at the home. Because in the sniff, somebody brought you your pills in the little cup at the right time. That person did not come home with you. So what are you going to do about this? And what level of ability do you need to be safe and able? And I think a lot of our care planning has kind of slipped into the, can you walk room to room? Okay, can you carry something when you do it? Because we religiously on the physical therapy side teach people about make sure 2 hands are on the walker. How many hands? 2 hands, always 2 hands so you don't fall. Remember my goal about don't fall during this episode of care? But I'm at home. What am I going to do when I need to get my clothes to get dressed? I'm going to have to use my hands. I'm going to be doing my self-care. Okay, I let go of the walker. I need to get a sandwich. I'm letting go of the walker. I don't see this being documented in the home health space. What about pet management? What is involved to manage the beloved pet? The pet they like way more than you. There's all kinds of balance and strength and cognitive and planning and all kinds of activities related to this. And in my 25 plus years in home health, with 20 of them religiously being tasked with reviewing other people's documentation, I have seen pet management mentioned once, literally once. Well, why would I don't treat pets. You're not treating the pet. You're making the case to CMS that the value of therapy is not just in getting people to a better condition or stabilizing their condition for the sake of doing so, but it is functionally relevant to these individuals. This is what they want to be able to do. This is why we hear I want to be at home. I don't want to be in a skilled nursing facility. I want to be in my home. I don't want to go live with my daughter. Well, what are the risks that would land you having to go live with your daughter? Well, if I can't get my clothes on by myself anymore, if I can't take care of the dog, they're going to take this dog away from me. We can step into that space because our value is not just giving, information back to the third party payer that they want by virtue of publicly reported outcomes, but are we clear at the same time with the rules expectations around being patient centered? Are we really seeing, in all my time as a therapist, I have never heard anybody say to me, you know what I really want? I want to be able to ambulate 250 feet with a walker and standby assistance to the mailbox. That's the pinnacle of everything I want to be able to do. So we have to really be evaluating what we do and why we do it in the home health space. And I think what we are hearing by virtue of some of the questions I saw ahead of this is this perception that there's little we can do. There's less we can do. You're not supposed to see them very often. This is good enough. If they get out to the driveway, then that's it. They're supposed to go to outpatient. And we're limiting and we're believing that to be accurate. That's not what CMS is asking. CMS is not even particularly focused on therapy specifically. They're looking at the bigger picture. Always. Are you keeping people out of the hospital? Are you keeping people out of skilled nursing facilities because it's expensive? And we have huge potential in this space to be able to address that. But we have to acknowledge that utilization, particularly under Part A, has been challenging to justify at times. When you look at the data of every time you change the payment model, therapy practice changes accordingly, raises suspicion about decision making, and provision of therapy in the home when it's an ALF. And is it A? Is it B? Are they getting put in B when they really should be in A, but the Part B is picked a gym site in the ALF, so now everybody gets that way? CMS is aware of that as well. They're tracking utilization of these services in the ALF setting. Those things shouldn't discourage us. They should just give us proper context to say, all right, but the bigger value is what? And how do I, as a therapist, contribute to that? And it is a huge opportunity for us in this particular space. So I know, Sherry, you've been keeping an eye on the Q&As. At this time, if there's some remaining to be asked, if there's things that have popped up in your head as we've gone, now is the time to ask the question. As people filter in with that, you will see there are, making sure I count this right, 1, 2, 3, 4 additional slides after this. If you look at that and you say, listen, lady, it's a handout and I can't read any of this, I'm going to go squinty blind. You have my email address at the end. I can send it to you bigger if that helps. But I want to make sure we're armed with research, with resources, with Medicare references, because too often as therapists, we're told, as I said at the beginning, you can never do that, or you should do this. Okay, I want to see the source. I want to see where CMS actually says that. If you're telling me the Practice Act says no, show me where. This is not about being belligerent. This is about being informed, because the home health space has been riddled with, there's, for every real rule, there's like 10 fake ones that maybe used to be true. Somebody heard at a conference, somebody thought once. No, we need to make sure we're following real rules and following accordingly. So any thoughts, Sherry?
I do not see any other questions, but I did answer a couple that were particularly regulations where I gave them the link to the regulation, but one just popped up. When a patient resides in an assisted living facility, does this change their homebound criteria in any special way, or is it handled the same as if someone lives in a house?
From the technical perspective, an assisted living facility is treated no different than if they lived in an apartment building. It is not a skilled facility. It is not held to regulations by CMS. So yes, you are correct. It is treated as if it were any other home setting. And this is why things can get a little tricky, because you say that, Cindy Krafft, but they have a nurse on site. So if I'm providing them therapy, under Part A, and I don't put nursing in because they have a nurse, okay, what is that nurse actually doing? Is that nurse available to the intensity this individual needs, and by virtue of being homebound and skilled need would qualify for a home health nurse, then we should be providing that as part of our care. They need an aide. Oh, but the ALF has an aide. They pay for an aide. That's a big sticking point, because if they're under a Part A episode in an ALF, an aide is part of that at no additional cost to them. Now, if they tell you, I love my aide and I don't want yours, that's fine. And I need to document I offered it. But I can't just, no aide in the plan because you already have one, because that looks like I did it to save cost to me for something the patient was actually entitled to because they were receiving services. I believe Part A and Part B can absolutely coexist in the ALF, but we both have to treat this as their home. And it's not the same as if we tried to do this in a skilled nursing facility, which we know we don't do for a variety of reasons. It's not supposed to be done that way, but it is their home. And so I wouldn't say there's special things about homebound status. It's contextual as if they were an apartment building. So let me give you a quick example. The infamous to a mailbox seems to be where most people think it's 100 to 150 feet away from their house. My mailbox, I've actually measured, is closer to 900 feet away from my mailbox. My ability to get to it is very different because of where I live. In an ALF, it will then matter. Am I in the apartment the furthest away from the food source? Then the expectation of what I need to do to be successful can be very different than if I'm right by it. But it's also not just within that building. For them to go out and go to the doctor, to go to church, to go visit a friend, how easy is it for them? Oh, they cannot possibly do that. Then they're in a wheelchair and they're taken out and they're put in the bus. And when they come back, the pain is worse. That's homeboundness. If they can come and go as they please, then okay, homebound does not appear to be an issue for them. But if them leaving that place requires that kind of taxing effort and they come back and they're wiped out from a doctor's appointment, you can't come, I'm just done. That actually reinforces homeboundedness and Part A.
And I'm sure you mentioned it, Cindy, but they are, there is a special code for patients that reside in an ALF and home health now, because they are aware of the data spikes around utilization in therapy and utilization in Part B and Part A in the assisted living facility. So everyone should just be aware of that.
Well, what it comes down to is, again, Part A and Part B can absolutely coexist and provide appropriate levels of care in an assisted living. When that morphs into, for lack of a better word, a pseudo nursing home, so the building is portraying itself as, oh, look at all this therapy you get, and you get this and you get that by living here, to the point where these people don't necessarily qualify. They're just being passed back and forth to therapy, so the place can say, look at all this therapy that we have, or that you're now finding individuals living there that are way worse than should be living in assisted living, but they're staying there because the building wants them there and expects you to provide all this care to keep them there. That's the kind of stuff CMS has grown concerned about. And Sherry's absolutely right. On the Part A side, a couple years ago, there is a indicator on the claim telling CMS from the jump that this individual resides in an ALF. Only time they ever have us report specifics like that is they intend to look at what is the utilization issue and what are we seeing specific to that living situation. All right, keeping in mind, I know that we have a time today. Sometimes questions come up later, or sometimes you don't really want to ask a question during the conversation, or you got to get out the door. That's fine. That is why I have included an email address here at the end. I welcome those questions. If you think of a big question between now and Part 2 that you'd like to see addressed in there, please reach out. Our goal is to give you as much information as we can about the provision of therapy in the home. And Sherry and I look forward to continuing the conversation in Part 2, where we're going to focus more on these value and quality measurement type endeavors, and where the therapy role is going to be crucial with respect to determining how we shape this setting going forward. So thank you very much for your time today. I'm going to turn it back over to Sabrina if she has any closing remarks before we end.
Thank you so much, Cindy and Sherry. That was absolutely awesome. Getting lots of text and messages. Everybody really enjoyed it. Just a reminder, we did put in the chat the link to the handouts. That is also a link where you will be able to find the recording of today's webinar. Lots of people have mentioned that they want to go back and re-listen to it. I absolutely loved some of your key phrases. I'm totally stealing some of those, by the way. I was rolling over here. And so the link will also have the recording that'll be available by the end of day, Friday, March 4th. And for all of our NARA members that are on, the recording will actually be posted into our member portal by end of day tomorrow. And I know everybody loved today's webinar, and looking forward to the next one. So I want to remind everybody to go on NARA's website and to register for the recording on March 16th. So thank you so much, everyone. Thank you again, Cindy and Sherry, and have a great day.